right, hello and welcome everyone. I am Rachel Hughes. For those of you who don't know, I'm the new community manager at Alloy Women's Health, and I'm joined today by Dr. Mary Jane Minkin. Before we get started, and I enjoy the pleasure of introducing my first webinar guest, I want to say a bit about Alloy. Alloy is an online menopause platform offering access to menopause-trained doctors, medically vetted information, and evidence-based solutions sent straight to your home. Today, Alloy is offering $20 off your purchase. Use the promo code DEBUNK20. It will be in the chat as well, I'm sure, at myalloy.com, and is a coupon that may be used by new and existing Alloy customers on perhaps a new purchase. Finally, this webinar is being recorded and will be posted on Alloy's YouTube channel at myalloy in a couple of days. Now, turning to our renowned guest, Dr. Mary Jane Minkin is a clinical professor in the Department of Obstetrics, Gynecology, and Reproductive Sciences at the Yale University School of Medicine and has been in private practice in New Haven, Connecticut for more than 40 years. Dr. Minkin is board certified in obstetrics and gynecology, and she practices at Yale-New Haven Hospital. She is a fellow of the American Congress of Obstetricians and Gynecologists and has been a North American Menopause Society, I suppose we should say now, Menopause Society certified menopause practitioner since 2002. Dr. Minkin has been director of the Sexuality, Intimacy, and Menopause Clinic in the Division of Gynecological Oncology in the Smilow Cancer Center at Yale-New Haven Hospital since 2008. She's also been director of the Yale Obstetrician and Gynecological Society since its inception in 2006. She's a multiple award recipient, nationally known in the field of gynecology. She is an author, a speaker, and advisor. She's also a podcaster. The name is Lady Parts, and her website where you can find everything and anything pertinent to your reproductive health journey is madameovary.com. Welcome, and thank you so much for joining us here, Dr. Minkin.
Rachel, thank you so much for the very kind introduction. You're too kind, and we'll hopefully have a good chat today and be able to answer questions for folks.
Absolutely. Let's dive right in to those. Today, we are focusing on the myths of menopause, and you and I had a chance to commiserate a bit on what that list might include, and we came up with really the same list. So that, at the very least, sort of reminded me that there are certain tried and true things that people understand, and or I should say, there are certain myths that remain, and they're loud and they're persistent and they need to be debunked. So the first is the false notion about breast cancer, that estrogen is dangerous and leads to breast cancer. Could you speak to us about that?
Sure, and there's actually been a lot in the news over the last 8 months or so. For those people who saw it, I'll just remind you, there was this exciting article in the New York Times Sunday magazine in the beginning of February or so by a Times writer named Sue Dominus. And the title of the article was "Women Have Been Misled About Menopause." And that really unleashed a whole host of discussions and things like that. And I think it was truly a landmark article. And indeed, the Menopause Society, we just had our annual meeting 2 weeks ago, and Sue Dominus was our keynote speaker. So it's sort of, hit doctors, hits patients, most importantly. And what basically she discussed in detail was the Women's Health Initiative study, which was published about the first paper came out about 21 years ago. As I say, July 9th, 2002, not that I remember the day, and not that I ever had any more phone calls than I had that day, about 50 phone calls before noon, when it was announced on the talk shows, the Today Show, Good Morning America. And what it basically said, this was a large study that was being done. It was what we call a prospective randomized double-blind controlled trial, one of the fancy stuff in medicine that we do. And it was given women estrogen therapy. If women had no uterus, they had hysterectomy, they just got estrogen alone. There was another arm for ladies whose doctors had not taken out their uteri, and they were on estrogen and progestin, which is a combination we use for people who have a uterus in place for hormone replacement therapy. And what happened is the study was designed to say, does estrogen help prevent heart disease? That's what the whole study was about. And indeed, what they found in the study was surprising to the investigators, that it did not indeed show that heart disease was prevented by estrogen therapy. But more tellingly was the fact that they had a downside risk study group for complications. And they said, oh my goodness, it looks like the ladies who were getting the estrogen and progestin, ladies who had a uterus in place, had a very slight increased risk of breast cancer. Okay. And so they stopped the study. Now, of course, the increased risk of breast cancer was announced on these TV talk shows, and everybody immediately went to their toilet and flushed down any estrogenic substances they had in their house.
Yeah.
And so that was basically what happened. So that's the background summary. A lot of other information came out of the WHI. Now, a couple of things that you have to, which were not discussed, was indeed that when the results of the study were published, that indeed the increased risk of breast cancer that was supposedly seen actually wasn't seen because, and for people who are familiar with statistics, the value was not statistically significant. So the magazine published some stats that really did not hold water numerically. That was number one. Number two, that the estrogen only group of this study, which were women who had a hysterectomy, which was almost as large as the group of women who had not had hysterectomies, actually was continuing because that actually ended up showing a decrease in incidence of breast cancer. Not only not a neutral, but a decrease in breast cancer, although that wasn't quite statistically significant at that point. But all sorts of assumptions were made. And what happened is because the hullabaloo that the study started, that everybody just stopped taking their estrogen. And it had a sort of a considerable effect because what happened is not only did women who were, taking estrogen at the time said, nope, I'm stopping this because of the study. But what happened is that many of the residency programs in obstetrics and gynecology basically stopped offering menopause education at this point.
Wow.
So what happened is residents who were trained in the United States after the year 2002 had very little exposure to menopause education. So it was left for us old farts to carry on. Did not get any education, which was too bad. So anyway, and so if you are, so many of you, I'm sure, are going to your healthcare providers and wanting to talk about hormonal issues or talking about menopause, and you're finding that your provider really doesn't know much about it. Well, it's not her or his fault because they just weren't educated about it. But I feel bad for the patients who aren't getting the information. That's the problem.
Sure.
So we are now trying to remedy some of this information and trying to expose our youngins to more education, making women aware of what's going on, telling women about resources so they can get hormonal therapy if they'd like to do it. And again, the key thing is we also, that was an old study, 21 years is when it came out, but we actually have some safer combinations these days, which probably have really no risk at all of increased breast cancer, but that people aren't even aware of them. So anyway, it's really too bad. So you want to go to a healthcare provider that knows your issue. So when you somebody says, oh, I can't take it because it's too dangerous. You want to go to a healthcare provider who really understands the data. Okay. And I can tell you how to find them. Okay?
Yes, please do.
The way to find a healthcare provider who's menopause literate is to go to the website menopause.org, which is the website of the Menopause Society, formerly the North American Menopause Society. And you can plug in your zip code. There's part of the websites is for providers, part of it for doctors or other professionals. And go to the website for patients, plug in your zip code, and they will give you a list of providers within a 10 or 20 mile radius, whatever you want, of your area. So you can find somebody who's menopause literate for you to help you.
Thank you for that, Dr. Minkin. You're bringing up a lot of things I'd love to deep dive further into, which we don't have to cover all of that now, but would love to speak with you again about the education piece. And certainly one thing that comes up for me, and this is not something you mentioned, but I am thinking about all of the women who were either taken off or stopped taking, which you did mention. I'm just so curious if you know of any women who said, no, I'm staying on no matter what.
Sure. And my patients did because I knew the data and talked to them about the data and educated them about the data. And basically, even if you accepted the WHI data as it was, okay, and say, yep, it's all true, okay. There's things, and again, this gets into some fancy statistical terms. There's what we call relative risk, and then there's absolute risk. I like to think about absolute risk. And baseline in the group of women they were studying, people of this age, unfortunately, breast cancer is a very, very common disease, unfortunately, for women. And basically, the background rate of cases of breast cancer in sort of the control group, the normal women who weren't taking any medication, is basically, it was about 30 per 10,000 women per year. Okay. In the group of women, in the highest reported rate here, the rate of being diagnosed with breast cancer after 5 years of therapy, this was not shown until after 5+ years of therapy. In that group, it was shown to be 38 per 10,000 women per year. So the absolute risk that can be attributed to the hormonal therapy that they were getting was 8 per 10,000 women per year. And I like to discuss that with my patients. And again, I'm a great believer in shared decision making. I mean, I want to share what I know, what I've trained to talk to people about, and let them make the decisions. My patients are smart. I may know a little more medicine than they know, but let me talk to it in terms they can easily understand. And I can say, okay, if in this paper, in this study, that the absolute increased risk of being diagnosed with breast cancer after 5 years of estrogen plus progestin therapy, ladies who had a uterus, was basically 8 per 10,000 women per year. And if somebody says to me, you mean to say with that number, I've got to suffer the kinds of things I've got to suffer my hot flashes, my lack of sleep, my achiness, my bladder symptoms, all these fabulous things. And that's the risk that I'm exposing myself to. And they say, the hell with that. I want to take my estrogen. Those are the ladies that kept taking their estrogen.
Fascinating, really interesting. Thank you so much for that.
You're welcome.
Moving on, myth number 2, vaginal estrogen is contraindicated for breast cancer survivors, among others, and increases the risk of breast cancer. You also mentioned, when we had occasion to go back and forth about this, the black box package insert. So if you would, if it's not really conflating two incorrect things, share on for us. Thank you.
Basically, all FDA-approved products available for sale through pharmacies in this country come with a package insert, and it has certain things about the product in there. And if somebody says, oh, this is really bad, they put it in sort of like a black border box. It's a black box warning, okay? And estrogen, after the WHI was published, the results, that the FDA put a black box warning on estrogen, on systemic estrogen, basically stating all the findings of the WHI. The problem is they also put the same identical black box warning on vaginal estrogens, which were not studied at all in the WHI. They weren't studied in the slightest. There are many studies about them, but they were not studied in the WHI. And basically, there is data that shows that the amount of estrogen that gets absorbed vaginally is minuscule. And both the Menopause Society and the American College of OBGYNs have issued position statements based on data. It's not like, oh, I think this is the case. No, based on data that shows that basically they state in there that women who have breast cancer may safely use vaginal estrogens. Okay. Now they say, yes, try to use one of the non-estrogenic products first. But if it doesn't work, yes, they may safely use vaginal estrogens because the absorption is so minuscule. And so when my patients get this package insert, it's like, I'm going to die. I said, no, that's not what this says. Okay. And indeed, I pull out my position statement from the American College of OBGYN saying this absorption is so low that we're allowed to use this in people that have breast cancer. Let alone you, who's even thinking about having breast cancer. So, this really is not an issue. And basically, almost every woman, now there are a few people who would be an exception, but almost every woman can safely use vaginal estrogen. And that's such an important thing because so many women do have vaginal dryness. Now, there are over-the-counter remedies, which are quite good, but some people will not get total relief from these. And that some people will have persistent pain with intercourse. And the other symptoms that most women don't think about, understandably, is bladder symptoms. And it's, my vagina is dry. Why is my bladder a problem? What are you telling me that this is related? Because the answer is that the bladder and the vagina are actually attached to each other. Okay. And when we're doing a hysterectomy, for example, we sort of have to pull the bladder out of the way so we can get in and take out the uterus. That's how attached they are. So anyway, and the tissue that lines the bladder is very much the same as the tissue that lines the vagina. And it has what we call these estrogen receptors. And when you think of receptors, sort of think like Pac-Man, going grabbing on to, to these molecules floating around. And so the bladder has estrogen receptors just like the vagina does. Okay. And so when the vagina is getting dry, you can bet your bippy, as we used to say in the old days, that the bladder's getting dry too. Okay.
Right.
And why is that important? Well, it sets you up for urinary tract infections. Okay. And leakage, which I know some of our listeners may not admit to anybody, but they're worried about it. So leakage, infections, prolapse issues, things like that. And so vaginal estrogen can be very, very helpful besides alleviating pain with intercourse and dryness.
Thank you for that. I'm so glad that you sort of dove deeper into the benefits of vaginal estrogen. I recently had occasion to speak to a group of women about perimenopause and menopause and sort of looked everyone in the eye and said, vaginal estrogen is your friend. And it was fascinating to me how many women, their understanding of vaginal estrogen was actually somehow connected to lubrication and intercourse, and that further than that, that's what vaginal estrogen was.
Right. Absolutely.
And so I'm thank you for getting further into that.
Well, thank you.
If I might, Dr. Minkin, I just want to let people know, I see some questions have come in. I'm not ignoring them. I'm just getting through some of our direct questions for Dr. Minkin, and then I will in fact turn to yours. Okay, next. Libido always declines in menopause, and there is no therapy for this. Could you speak to that myth?
Well, libido does not always decline in menopause. I certainly know that. Certainly, there are many women who do state that they've noticed a decline in their libido. That's absolutely correct. But there are ways that we can help this. Okay. Now, of course, the other thing with libido is that sex drive is really, really multifactorial. And that there are many things besides just hormones that contribute to lack of libido. And somebody that I've led a very lucky life. For anybody, I'm a very lucky person, and I had the significant privilege a number of years ago of working with Dr. Ruth Westheimer, which is always entertaining to see.
Yes, I'm sure.
And we did actually a tour around the United States talking to a bunch of women's groups, and I was the doc and she was the sex therapist, and it's always entertaining with her. And a couple of things that she says about libido, and I still think that they're very apt today as they were 15, 20 years ago when we worked together. And one is that the most important sex organ, Dr. Ruth always says, is above the shoulders, not between the knees and the shoulders. And I think she's right on many aspects of that. The other thing, when she talks about libido in a couple, and Viagra was newly on the scene at this point when we were doing our programs together, and her standard example was, she says, then you have a couple, and he takes this blue pill, and it gives him, and I can hear her saying this to this day, an erection that goes from the floor to the ceiling. And she would say, and he says, come here, honey. And, he hasn't taken out the garbage, and he hasn't talked to her. If, God forbid, there's been a sports event on TV, she's supposed to come and have libido, No. And so there are a lot of things that can contribute to besides just hormonal stuff. Now, the one thing we do, it is now officially recognized by the North American Menopause Society, aka the Menopause Society, and the International Menopause Society, and all the big groups, that there is something that does seem to affect women's libido, and that giving them this substance tends to help, and that's testosterone. And many women are like, testosterone, that's the guy's hormone.
Right.
The answer is, yeah, they make more than we do, but they also make estrogen. Don't tell them that they do, but they make plenty of estrogen, but that's a secret. So anyway, but the key thing is that our levels of testosterone go down with menopause too, although we actually continue to make testosterone out of our ovaries till we're about 60, but at much lower levels, believe it or not. Yeah, but at much, much lower levels. So giving testosterone does seem to improve libido. And there's only one problem along those lines. And unfortunately, the FDA has, I'm dumping on the FDA a lot today here, but the FDA has yet to approve a testosterone product for women. There are tons of these guys and you see the ads on TV, the guy riding the motorcycle up to the gas station and he's getting his testosterone and stuff like that. So there are a lot of testosterone products made for guys, but not for women. So we can use the guys' stuff, but just a teeny amount of it because we don't want to use the amount that they're using. The other possibility is you can get it from a compounding pharmacy, but unfortunately, there's no official FDA-approved testosterone for women available on the market currently in this country.
Okay.
There is one in Australia, if you can get it from Australia.
Right, but not here in the United States.
There's one in the United States.
Okay, so libido does not always decline in menopause, and there is, in fact, a solution.
Yeah, and one thing to remember, for example, that some women have terrible things that they've had in their lives related to their premenopausal lives.
Sure.
I mean, people that have had fibroids, have had endometriosis. These women have been oftentimes miserable for years. And they go through menopause, fibroids shrink, endometriosis shrinks.
Right.
So these painful conditions or bleeding conditions that they've had get better, and they may be more inclined towards having sex. And the other thing is that a lot of women who are afraid of using contraception or are part of a religious group that doesn't allow contraception, and what comes out of having sex is babies. So many women are now liberated that they can have sex without producing a baby, which they didn't want to have. So for many women, menopause can be a very liberating time of their life.
Freedom. Yeah, thank you. Thank you so much for that. Okay, on to the next. Hormone therapy makes you gain weight. Myth number 4. Could you speak to that?
Well, and what we didn't do is we didn't do an official poll through the Gallup organization or anything to say which is the most common, but they're all very common.
Right.
Unfortunately, women do tend to gain weight in menopause, going through from the menopause transition, the so-called perimenopausal state before we become fully menopausal. And the average weight gain, now some people don't think there is, but I think most of the literature would say, yeah, it does. And the weight gain is typically about 5 to 8 pounds from the beginning of the menopausal transition through perimenopause and to that one magic year without the period. Now, that's an average. So some people gain a little more, some people gain a little less. When a patient comes into me and says, oh, I hate this menopause. Well, why do you hate menopause? I've gained 40 pounds. Right. That is not menopause. Okay. My problems are cookies and French fries.
Yeah.
That's my downfall. So anyway, so the key thing is it's unlikely it's going to be more than that. What I can say is that's just for menopause alone. That has nothing to do with hormonal therapy. And if you look at women who do take estrogen through the menopausal transition, their average weight gain actually is about 4 to 7 pounds. So what I tell people is, please, I'm not going to give you estrogen to make you lose weight because the difference is about 1 pound. So that's not worth it. You take estrogen for other reasons. But what I can say is that there is some weight gain, but it's not huge. And if you obviously try to eat a careful diet, not to eat too many cookies and French fries, like I can do on occasion. Or the other thing is, of course, getting a lot of exercise. Yeah. And that both aerobic and strength training is very important during the menopausal transition and postmenopausal years. And the strength training not only is good for your health, cardiovascular health and things like that, you're going to build muscle mass, utilize calories better, which is always a good thing. But the other thing is that the strength training is good for your bones. And unfortunately, one thing that happens to us with menopause, with the loss of estrogen, is the fact that we lose bone. And so everybody is at risk. Any menopausal woman is at risk, and doing strength training will help prevent that.
And menopause hormonal treatment will also.
And menopausal hormonal treatment absolutely will. And the time of most rapid bone loss is actually the first 4 years after menopause, after you stop having your periods. So that first 4 or 5 years is the time of most rapid loss. And so if you can get on some estrogen at that point, that will very effectively prevent that bone loss.
This is not about me, but I'm going to make it about me for just 1 second. But I found that menopause hormonal treatment helped me kind of like get my arms around weight gain. I felt like before treatment, I was in a perpetual state of PMS. And I was very, very cravey and sort of bloated and uncomfortable and all of that. And for me, it took a little while, but not that long. And things just kind of settled down and evened out. Is that my mind or?
No, I don't think that's, I think, yes, it is your mind, but in a good way, because hunch is the mechanism of action for a lot of people, I think, is better sleep. So, and it's talking about, yes. And by the way, when I always tell you, please feel free to use this line when somebody sort of looks at people and say, oh, it's all in your head. You know, yeah, what you're supposed to do, I think, is to point your head and say, yes, dear, it is in my head right here. It's in my hypothalamus, which is right here behind my finger. And so, yes, it is in your head. But basically what happens is most women in menopause do have some sleep issues. And it's not necessarily even that they can't fall asleep because they're exhausted. They pass out, but they wake up frequently. They wake up every 2-3 hours, takes them a while to get back to sleep. They sometimes wake up with hot flashes, sometimes just spontaneously. And that can be rough, and the quality of sleep can be bad. And one thing we do know about weight situation is if you're not sleeping well, you will not lose weight well.
Yeah. And that was a big factor for me as well. I just want to take a second and remind everyone about our coupon today. It is a $20 off your purchase. The code to use is debunk20, which Dr. Minkin really likes the name of. Okay, I'm moving on to another myth. This one's really interesting and I think confusing for a lot of women. Only severe menopause symptoms need treatment. And with that you cannot begin MHT in perimenopause. Can you speak to that?
Yeah, that's well, we could talk for several hours, so that's okay. No, I'm happy to chat. Anyway, I don't think people want to hang on that long, but anyway. So interestingly enough, hot flashes, which are attendant at 80% of women, 20% of women get no hot flashes, and we have absolutely no idea why they don't. Their estrogen drop is the same low drop. We just don't know why. About another 20% get very severe hot flashes, and the other 60% are sort of in the middle there. But the hot flashes tend to be worse early on in the menopause transition. So over the course of time, they do tend to get better. Okay, so the hot flashes tend to be worse. And as far as, and so basically in perimenopause, a lot of people get pretty severe hot flashes, no question about it. And there used to be a feeling many years ago that folks would wait to start hormone therapy until somebody had gone that magic year without the period. And the rationale for that actually was if you started doing some funky bleeding, okay, that if you were in perimenopause, you'd do funky bleeding anyway. So nobody would be able to tell whether that was pathological funky bleeding or just perimenopause funky bleeding, i.e., could this be representing a cancer or something like that in the cervix or the lining of the uterus? And now we've come to the realization, no, I mean, people can be pretty symptomatic in the perimenopause. Let's go ahead and give them some therapy, and we can balance out their estrogen other ways. It's not a problem. And obviously, if somebody has some significant risk factors and they do some funky bleeding, I'm going to biopsy them. I'm going to do an ultrasound. I'm probably going to biopsy them to see what's going on. But as far as can you start the estrogen, is it safe to start the estrogen? Yes, it is, under supervision. Now, the other proviso that I'm going to say to everybody watching here is that, and this is true among, I think, almost all menopause docs, PAs, nurse practitioners, we all know perimenopause is a tough one to treat. Menopause is easy. Give me a lady who hasn't had a period in 2 years, no problem. I can take this really easily. If she's still having a period here and a period there, and sometimes she bleeds and sometimes she doesn't, and sometimes it's heavy, that can be tricky because what's going on in the perimenopause is you're starting up with a high level of estrogen as you enter the menopausal transition, and you're going to finish up low, okay? But it's not a straight curve down, and it's a very jaggedy curve. And one thing, a picture that I always kid around with my medical students, I draw them a graph, and I say, now this graph is the Dow Jones Industrial Average in September of 2008. It's very jaggedy, but he ends up low. And I say, this is also a graph of your hormones in perimenopause, because it looks just like the stock market in 2008. So the thing is, it's nightmare. It's all over the place. So one day your ovaries are chugging out a lot of hormones, and the next day they may be doing nothing. So on the day they're chugging out a lot of hormones, you may be getting some sore breasts. The next day you may be getting sweats and hot flashes and sleeping miserably. And all that stuff is going on in perimenopause. So you have to treat these people. Now, I make a little sidebar here. Please. We do have some very effective ways to take care of perimenopause. I mean, one of my favorite combinations to use for perimenopausal folks is actually a low-dose birth control pill. And now, as long as she's a good candidate. Now, if somebody's sitting there smoking her cigarettes, no, I ain't going to give her birth control pills because 35, you're not supposed to be smoking. Well, you shouldn't be smoking anyway. But the key thing is that, you try not to give birth control pills to somebody who's a smoker. But the key thing is, if you have my standard line, you have somebody that goes to the gym 24 hours a day and eats nothing but sprouts. I mean, that's my typical, very healthy person. She's a good candidate and she's non-smoker and, doesn't, no significant risk factors for, blood clots. That she's somebody that I would love to give a birth control pill to help control the symptoms. Because what does the birth control pill do? It shuts down ovulation. So it shuts down all over the place. And I try to do this in my best robot voice. And I am giving her a fixed dose. So the key thing is that I'm giving her no variation in her estrogen, and her body likes that. It likes a constant level. It doesn't like this, up and down, which makes her feel awful. So if I can give her a fixed level, then it's great. To me, there's only one problem with giving a low-dose birth control pill to a perimenopausal woman, because she's probably going to keep on getting periods from the birth control pill. Right. So the issue is, and you can't measure hormone levels when somebody's on a birth control pill, because you're going to measure the hormones of the birth control pill. Well, that's nice. She's taking it. I know that. Right. I don't need a blood test. So the key thing is that as far as, we can't tell when she's fully menopausal. We have only way you're going to find out if her ovaries are out of the picture is to stop the birth control pill and find out.
Can I just interject for a second and just say, I am so glad to hear you speak about your using a low-dose birth control pill for women in perimenopause. That was my next question, actually, but your description of it is so helpful. And the reason I'm really glad that you brought it up is because many women, myself included, in perimenopause were offered a low-dose birth control and told, you know what, you can stay on this. Just stay on it. My gynecologist told me to stay on it till about 52, get off and see what happens. Now, I didn't. That wasn't the protocol that I chose to adhere to. In retrospect, I wish I had. But what's so important, I think, is that many of us are hearing that information and sort of balking at it and feeling like, what? That's all? I did that already, or I don't want to be on that again. When in fact, it really is a terrific tool for women who are still in perimenopause.
And it's also terrific for one other thing. It's good as far as preventing pregnancy. That's what it's supposed to do. And until you go that magic year without a period, you can get pregnant. Yeah. And my personal best here is I have delivered 3 47-year-olds who were not infertility patients. These were oops pregnancies.
I personally shudder at the thought, but I'm down with everyone's choices. But I think that actually came up as another sort of myth between us, is that you can't get pregnant during perimenopausal years.
You can. And my favorite example, my favorite stories, and gynecologists, I always say, they're most anecdotal people. We love to tell stories. And the reason I think we love to tell stories is, in our training days and our days doing obstetrics, that you're up at night at 3 o'clock in the morning on the labor floor. So what do? You entertain each other, tell stories. It's fun. I like to tell stories. But this is a true, honest to God story. One of my patients who came to see me because she was 46 years old, she'd been perimenopausal, and her weight was just going up, and she couldn't control her damn belly, she told me. Oh, wow. Get her on the table, and her belly was a little more prominent. And I took out my Doptone, and I heard that nice fetal heart. So anyway, she was about 20 weeks pregnant. So anyway, long story short, whatever, but she decided to keep the pregnancy and went on to term. But the amazing thing was her older daughter's wedding was scheduled for the due date. This is a true story, absolute true story. So what they did, they postponed the wedding for a month so the new baby could come to her sister's wedding.
Oh my God. That's adorable. That's very sweet. But
in case you don't want to have that story happening to you, remember contraception.
The birth control pill. This is not a myth question, but I am wondering about those women who are postmenopausal and their ability and access to use menopause hormonal treatment. Could you speak to that?
ability to use it. Most everybody can use it.
So you can use it, let's say you're 8 to 10 years postmenopausal.
Let's talk about that.
Okay.
That's the major.
That's a different thing. Okay.
That's a different thing. And the major question is, and this is why the WHI study failed as far as showing cardiac protection, we think, because the WHI study was started to say, does estrogen help protect the heart? And their conclusion was not. However, the average person's age in the WHI was 63. Now, the average age at menopause is 51. So the typical patient in the WHI study was 12 years after her last period. And indeed, there were some women who were 50, but there are also some women who were in their 70s. About 20% of the women in the WHI were between the ages of 70 and 79 upon enrolling in the study. Which is, I don't start too many 75-year-olds.
Right. Sure.
So anyway, so if you look at what we call the gap time, the time between the time the woman went through menopause and the initiation of hormone therapy, if it was a long period of time, it seems that it was not favorable for prevention of heart disease. It may actually, if anything, accelerated it because it does increase the risk of clotting when you use an oral estrogen and stuff. So it could be. But again, if you have somebody who's within, and basically the magic number that people tend to use is about 6 years. Of her last menstrual period. Now, some people will say up to about 10 years that we have reasonable data to say it's okay to start estrogen, and that it probably will give you some degree of protection for your heart.
Okay.
But we're not officially supposed to say that per the USPF, whatever task force. But if you are starting it early, there is data to show that an early initiation is good for you.
Okay, terrific. Thank you for that. Finally, and this is by no means, as you pointed out, the last of the myths, and this is in no particular order, but finally, and this is also a really important one for many, you can't take an antidepressant and estrogen. That is a myth. And would you speak about that?
No question a myth. Now, why is that important to talk about, though? Because depression is a real important issue. And if you look at women who have a previous history of a depressive episode, and that includes like PMDD, premenstrual dysphoric disorder, postpartum depression, those particularly reproductive related depressions, that those women are about at a 3-fold increased risk of getting depression as they go through menopause. Okay. Now, of course, with depression and menopause, it's hard to say because, again, we talked about sleep being miserable. And if somebody's not sleeping well, do they tend to get more depressed? Yeah, they probably do. I mean, that's probably going on. But we do know, and this is some interesting data, that if you have a woman who is a menopausal or perimenopausal woman, and she's getting depressed, yes, of course, you can give her an SSRI, SNRI, but some of these people will not respond to the therapy. However, there is some data out there that shows if you then give these women some estrogen to take as well as the antidepressant, it sort of, in a sense, primes the pump and they will respond much. So there are women who are refractory to antidepressant therapy that if you give them a little bit of estrogen with it, will respond much better.
Thank you for that. And again, I'm reminded of my recent occasion to speak to this group of women who many of them voiced that they were offered an antidepressant and offered menopause hormonal treatment. And they were kind of like, this is too much. This is this is all negative, negative, negative. Mm-hmm. And the little that I understood, you just so eloquently laid out for us, which is that there's a fit there. Yeah. And priming the pump is one. And then kind of drilling down deeper is what can turn the tide for so many.
Yeah. And we also discussed the fact that, one thing I should bring an ancillary to that. Mm-hmm. There are other therapies for hot flashes besides estrogen therapy. And we should probably talk a little bit about that there are other therapies out there. And one of them that's been recognized for years is actually SSRI and SNRI antidepressants. So for example, if somebody has a little touch of depression, okay, and they're feeling depressed for whatever reason, and you were thinking about, and they were also having hot flashes, that it is quite reasonable to prescribe an SSRI or SNRI, which may help with both. may help with her hot
Fascinating.
flashes and with her mood. So if somebody is, and again, I try to, when somebody comes in, I've got hot flashes, and like, what's the right therapy for her? I try to go through everything, say that these are your options, this is your choice, stuff like that. And then to try to narrow it down. And if she says, well, she's got some depressive issues, yes, I might say, let's try estrogen as well, because that might help an antidepressant. But certainly if she's really having anxieties about estrogen, which exist, I mean, people, again, have this, feeling, oh my God, this is not safe for me to take. If she's anxious about it, then we can always give her an SSRI or SNRI, and it might well work for her, for both.
Thank you. Thank you so much. Dr. Minkin, I'm going to turn now to questions that have come in. Some of them we did touch on. If there's anything you want to expand on, I'm going to lay out the question for you.
Sure.
Do you have suggestions for dealing with low libido? We spoke about that. I don't know if there's anything you'd like to add.
Well, a couple of things that I don't think we talked about testosterone in and of itself, which is important. A couple of things, and also a good relationship. There's very important, and to talk to people and stuff. We haven't taken out the garbage. Well, she's not gonna have a libido, as it says. But anyway, one thing though that I always ask people, I always ask somebody who's complaining about low libido, how's your vagina feeling? As far as pain with intercourse and stuff. And the standard answer, oh, it's awful, but that's not my problem.
Right. Yes, so great.
I look at my patient, I said two things. I said, number one, it may be your problem. I said, and the other thing is, if you want to be wanting to have sex, okay, well, am I doing you a favor if I make you want to have sex and it's going to hurt like hell? That's not a good thing. So anyway, I said, let me fix your vagina. I always say, let me fix your vagina. Let's use some non-hormonal stuff, use some hormonal stuff. Let's get you comfortable first. And it may take up to 3 months to get somebody comfortable, but you should be able to do it in that time frame. So I have people come in 3 months, or have them call me on the phone or email me, whatever. And I say, okay, how's your vagina? Great. It's perfect. No pain. And I say, how's your libido? It's terrible. So about half the time, taking care of the pain will do the job. Okay. But there are people I can make them totally comfortable and they still could care less. And those are people, I mean, obviously you want to try to help go through the relationship issues. Also, I mean, here's an example, a patient of mine who I know doesn't have much libido. She's like the most wonderful person I take care of. God bless her. She is a school teacher and she teaches a lot. And then after she teaches, she goes to her father's house, and he's like close to 100, and she takes care of him, gets him to bed. Okay, she stays there at night, okay, in case he gets up in the middle of the night. At 6 o'clock in the morning, she runs to her house to get changed and to say hello to her husband. What kind of a life is that? I mean, she's a wonderful person, God bless her. Yeah. But, it's,
at that point, who wants to have sex even? That's
exactly. So, I mean, so somebody like that, I mean, I know what's causing her,
Yeah.
I mean, she's a wonderful person, but it's just, she's sacrificing her whole life there.
Yeah. Thank you for that. When is it too late to begin estrogen therapy? We talked about that a bit as well.
Yeah, as I said, most people will say within 10 years, 6 to 10 years of the last period, okay, or some people put in as the extra age under the age of 60. So, for example, somebody who's went through menopause, at 45 or something like that, but it's been now 10 years since she hasn't taken estrogen, but she's still a very young person.
Yeah.
Want to give her some estrogen there.
Okay, thank you. Can you talk about the difference between estrogen patch versus the pill? Is one better than the other, particularly for benefits on heart and brain?
Excellent questions. Okay. And the issue is they are both available. There's no question about it. Now, patches are relatively new. They came about 25, 30 years ago. But when I was a little girl, we didn't have patches. Okay. They came on the scene then. And so all you had were pills. But basically you can get estradiol, and basically estradiol, which is basically the same estrogen that our ovaries make, 17-beta estradiol, is the estrogen that's in the patch. You can also get it in a pill form as well. Okay. The pill, some people just don't like patches. And in America, I think the Europeans are a little more forward on patches and stuff like that. In America, there's a little more hesitancy about it, although they're getting more popular. But some people have sensitive skin, don't do well with a patch. Well, for those people, there are estrogen gels that you can use. So you don't have to put it in a patch form. You can do some gel and rub it in. So that's certainly an option. As far as a health benefit, the major health benefit of the patch is it basically what we call bypasses the stomach on what we call a first pass effect. Okay. So bypass is liver, excuse me. It bypasses the liver, basically the liver sort of on the side of the stomach, and that the estrogen that you take in a pill form gets very quickly to the liver. Whereas the estrogen you use in a patch, everything gets to the liver eventually, but it goes into the bloodstream, it gets shipped around the body, goes into the liver, as does everything, but it's sort of a later on issue.
Okay.
As far as safety issues, the major things that you gain by using a patch as opposed to a pill is anything that happens with a liver-mediated effect. Now, what are those? Several things. One is blood clotting factors are made in the liver. Okay. So oral estrogen has a slightly higher risk of blood clots than a transdermal patch or the gel, something like that, transdermal absorption. Okay. And for many people, that's a bonus, particularly if you have a history of any blood clots or anything in the family. Now, of course, we would check for clotting factors, but basically, that's one major area. Also, people that have problems with what we call metabolic syndrome, that have high triglycerides, that triglycerides are also made in the liver. So patches are better for people that have high triglycerides.
Interesting.
Won't raise their triglycerides. Okay. The other thing that you can do with your patch, which is sort of secondary or tertiary as far as interest, is that when somebody's using a patch, you can actually effectively measure blood levels of the estrogen. Whereas when somebody's taking a pill, it's hard. I know it sounds stupid, but it's hard to measure a blood level of estrogen when you're taking a pill. So if for some reason you want to check somebody's blood level, are they getting a sufficient level? You want to do a patch as opposed to a pill.
And as far as sort of brain health, heart health.
Well, the issue with heart health is it's less risky for blood clotting. So if it has something related to clots, then the patch is more favorable. Brain health, it's probably not a huge difference, again, other than secondary to blood flow to the brain.
Okay, great. Thank you. I am 61, menopausal, or menopause 9 years. Can I benefit from HRT?
Well, that's a good question. And this would be a borderline call, okay. But I think it would depend on your health issues currently, okay. And if you had a lot of cardiac disease extant, I don't think most folks would say, well, take it now because it's going to reverse it. However, if you're basically in good medical health and, you're a healthy person, you don't have an elevated cholesterol and stuff like that, and you really decided now's the time you wanted to take it, many people would say, yeah, go ahead and do so.
Great. Thank you. You mentioned this. Weren't the women in the WHI study an older cohort?
The answer is absolutely yes. They were average age 63. A couple other things about the cohort. Now, unfortunately, it probably reflects America. But what can I say? That the average BMI was about 28 in the WHI, which is sort of in the moderately overweight category. And the other thing about there were a lot of hypertensive women on medications. And there were also a lot of smokers or former smokers.
Really?
Yeah. And so my standard line when I'm teaching my medical students about the WHI, I always say, okay, this is the average demographics of the people in the WHI. Now, who in this room wants to trade their coronaries for the coronaries of one of these ladies? And I look at the class because nobody's raised their hands. And I say, damn it, it's another class that nobody's raised their hands. So basically, they weren't starting with pristine blood vessels.
Okay. All right. Thank you. This woman writes, the Menopause Society search tool is really not helpful. They need a major tech overhaul to make it useful. And she comments that let's stop saying it's not their fault about doctors who won't discuss hormones. They do get training on hormones and have no issue discussing with men. We are the women who were completely ignored. This is an interesting.
Well, that's an interesting point. And what I have talked to Sue Dominus about, the lovely lady from the New York Times who wrote the article back in the last spring or late last winter. And I've told her, I said, I want you to write a follow-up article. Follow-up article that I want is that expression that our writer just wrote in.
Yeah.
That I'm mad as hell, basically.
Yeah.
I'm mad as hell. I was gypped.
Yeah.
And that is a reaction that I've gotten from many, many women who were motivated to come in because of that article. And so I said, Sue, that's the article you need to write, the I was gypped article.
I love that. And I think of this often, just to circle back to your much earlier point about education, that the people that you are educating, the people who are going through medical school now, our children who will be entering into medical school, who've now become familiar and curious, interested, demanding answers that their mothers have gotten more vocal about demanding, will, I hope, and I believe, kind of allow for this resurgence of menopause education for all.
I am hoping so, absolutely.
Yeah. Okay. How effective is paroxetine? Forgive me if I'm not pronouncing that correctly.
Perfect.
For women who can't take HRT because of previous blood clots.
Good question. And that's a very good question. Paroxetine is, until this spring, was the only non-hormonal product approved for vasomotor symptoms, for hot flashes. And the official product that was made was a paroxetine, very low dose, 7.5 milligrams. And it did not have enough SSRI to be antidepressant. And it also did not cause weight gain or loss of libido that many SSRIs can do. Problem is, it was effective against hot flashes, but not greatly so. Now, many people take other SSRIs or SNRIs, which do help with the hot flashes. So paroxetine is certainly fine. You can use the special preparation that was made for hot flash therapy, or you can use a higher dose, but it is effective. Now, the good news is there is a newer medication out on the market, which is clearly the most effective non-hormonal medication we have. Okay. And it's an interesting drug. It's called fezolinetant. And it was fancy term for it is a neurokinin B receptor antagonist. This gets back to it's all in your head. Okay. In our hypothalamus, near the temperature center, okay, there are these cells which basically are, people refer to them as candy neurons, and my patients all get excited. Except it's KNDY and it's kisspeptin, neurokinin, dynorphin. There's special kind of cellular receptors in these cells. And what's interesting about them, these cells bind with a molecule called neurokinin 3B, and they bind to these receptors. And what happens is when they bind to these receptors, it sets the cells up and they go wild. It's neurokinin's gone wild, and they go right to the hypothalamus, to the sleep center, to the heat center, and they burn you up and they make you wake up. And it's interesting. Now, the reason we don't have this happening in our premenopausal lives is estrogen blocks the neurokinin receptor. It's only when the estrogen levels go down that the neurokinin receptors are really excited and they start putting the heat up and stuff like that. So estrogen works by blocking the receptor. Well, that's fine. But if somebody doesn't want to or can't take estrogen, you can give her a neurokinin B receptor antagonist and block her hot flashes.
Amazing. Thank you for that. Dr. Minkin, I want to be sensitive to your time, and we're at just about an hour. Can you give us a little bit more?
Sure, of course.
Yay. Thank you. Okay. This next question is not about myths per se. Totally fine. Okay. I'm on HRT and I'm so very happy. I was just diagnosed with osteoporosis on the spine and osteopenia on the right hip. My primary prescribed Boniva, read the insert and honestly got quite scared because of the potential of calcium in the blood, etc. Could you speak to that? I have a healthy lifestyle, lift weights, eat well, and exercise.
All of which is good. Unfortunately, many people need a little bit more as far as maintaining bone health. And the key question about this calcium business, this whole business started about, does calcium cause heart disease and stuff like that? That was the major concern a few years back. And so many people had been telling women, no matter what their calcium intake, to take a supplement, that everybody should take a supplement. And the answer is no, not everybody should take a supplement. And what you really need to do is to calculate out what calcium you're getting on your own. Okay. And the richest foods out there are basically dairy foods. Okay. The second best, there are some green leafy vegetables. The best one is one that everybody eats, which is broccoli. Well, most people eat it. The other one nobody eats is kale. But unfortunately, what can I say? Broccoli au gratin, best dish in the world. So anyway, get the calcium from two sources. So basically, and as far as how you calculate this, one dairy helping, milk, 1 cup of milk, cup of yogurt, ounce of hard cheese, Swiss, whatever, and low fat is fine. Low fat has as much calcium as regular. That basically 1 cup of milk, cup of yogurt, ounce of hard cheese, about 300 milligrams each. Now, the recommended daily amount that women should get in is between about 1,000 and 1,200 milligrams a day. So if somebody's doing 3 dairy helpings and probably eating a little broccoli along the way or something like that, you're fine. You probably don't need additional stuff. If somebody's like, I can't stand milk, I hate it, I'm not going to take any in, and I hate broccoli, and kale's even worse, something like that. And I don't like sardines with bones, which is another option. Yuck, some people say. So anyway, so the key thing is if you're not getting any calcium, you want to take some. Okay. But this concern about too much calcium was really because people were told to take a supplement no matter what their intake was. So you want to get your analysis going, whatever there is. Now, the key thing is that the Boniva type drugs are reasonable options as far as bone strength. And basically the concerns about using the Boniva itself are greatly, or any of the bisphosphonates is what they're called, are greatly exaggerated. Okay. And just one of my favorite graphs in the world that I saw was a meeting of the Menopause Society in Chicago about 10 years ago. It's important it was in Chicago. And one of the most famous, we call these people boneheads, the endocrinologists, bone metabolism. And it was an interesting bar graph. And one was a very high bar, and then one next was a very low bar. And the high bar, and the reason I told you it was in Chicago, was basically the number of murders this year in the city of Chicago. Right. Low bar was the cases of a jaw condition called osteonecrosis of the jaw in the United States of America this year. Wow. So there is one very, very concerning jaw issue that happens, but it's extremely rare. And that was the point of the graph, is to say you're much safer taking this drug than being in Chicago. So anyway, which is probably true. But anyway, so the key thing is that I think it's important to be with the doc to talk to you about. And unfortunately, osteoporosis has its risks. As I said, if there was nothing dangerous about having some bones that are at risk, but unfortunately, and this is a statistic that some people say lies a bit, but if you look at older women who fracture their hips, that about 20% are dead by the end of the year that they fracture their hip. Yeah. So it's not a good thing to fracture your hip. If we can help prevent it, it's a good thing. So
thank you for that. Excuse me. Does vaginal estrogen increase the likelihood of uterine fibroids if you've had a prior history of fibroids?
The answer is probably not. It's unlikely. Again, the absorption up towards the uterus is pretty darn small. And if your fibroids have sort of receded with menopause, it should not be a problem.
Great. Thank you. I'm 45. I'm experiencing perimenopause. I would like to consider FDA-approved bioidentical hormones, yet had a provoked blood clot due to an injury last year. I stopped taking a blood thinner in September of 22. Am I exempt due to the blood clot and estrogen?
That's an excellent question, and it's a tough one. There is literature from Europe. Now, this is not prospective randomized data, but there's some observational trials that show that transdermal estrogen does not increase the risk of blood clots.
So this is the patch, everyone.
The patch or gel.
Yeah.
So there are people in Europe particularly who will use a patch or transdermal estrogen with somebody who has a provoked blood clot. They won't. Now, the key thing is there actually is one study that shows that even if you have one of these what are called thrombophilic mutations, the Leiden factor, factor V, factor hemoglobin S, hemoglobin C, whatever, that basically factor S and C. But the issue is that many people in the United States will say no, that it's not, even if you have one of these clotting factors, no, you should not be on estrogen, even if it's transdermal. So you want to talk to your hematologist, and if the hematologist will bless you being on it, you're probably okay.
Okay, great. Thank you. Do you have thoughts on Veoza?
I do. Veoza is a fine drug. And remember, we were talking about those neurokinin receptors? That's what we were talking about.
Okay.
Basically, not neurokine, that Veoza is, or fezolinetant is the generic name of it, is actually the molecule that will bind to the receptor in the hypothalamus and block it so the nasty neurokinin molecules can't go wreak havoc with the lady. So it's basically a substitute for estrogen in the hypothalamus, but it's not estrogen. It's totally unestrogenic. And so, so if you have a quote unquote contraindication to estrogen, it should not be a problem with Veoza.
Great, thank you.
There are a few contraindications, but minimal.
Okay. What about those of us who don't seem to get regulated by a low dose birth control? I've got PMDD and severe symptoms now. I'm 46. I just came to month 5 of June. I'm not sure. Junelle, yeah, sorry, 24FE. And my periods are still all over the place. And the pill seems to have a negative impact on my mood, sleep, GI, and overall well-being.
What you want to do is, not all birth control pills help with PMDD, unfortunately. And so what you want to do is, there is one pill that's officially approved for PMDD, and the pill is called Yaz. Okay, the generics are Nikki and a whole bunch of other ones. And you want to talk to a gynecologist about possibly switching to that, because that's the one that's officially approved for PMDD.
Great, thank you. Can you discuss progesterone treatment after hysterectomy? I'm taking estradiol gel, and apparently progesterone is needed to balance out the estrogen.
But you had a hysterectomy. But she had a hysterectomy.
She said, yeah, she discussed progesterone treatment after hysterectomy.
Yeah.
I'm assuming
if you've had a hysterectomy, you don't need you don't need progesterone to balance estrogen. Yeah. That's why in the WHI there were 2 groups. I think I have to be rude though in a minute or so, because I think I have a patient coming into
Not at all. My gosh, you've been so generous with your time. I'm gonna ask one more question and then close us out. I'm almost 3 years postmenopausal. All of this info, conditions of not being on HRT is scaring me. I'm overwhelmed with all of it, and I'm not sure if I should go on it. And might I say, Dr. Minkin, I wanted you to have just a moment to sort of let us know what's lacking in the discussion for you still. And this question kind of makes me think of what you might want to speak to. So
if you are 3 years after your last menstrual period and you say, gee, I really would like to go on estrogen after I've heard about these things, there is no reason you can't. No reason you can't. And what I would suggest that, again, if your doctor, nurse practitioner, whoever you see, and you don't have to see an MD, you can see a nurse practitioner, PA, somebody who's knowledgeable about menopause. And we have plenty of those folks in our organization, in the Menopause Society. But anybody who's saying, I don't know if I'm getting the right information, you can go to menopause.org, and there's a lot of information there, to read. Go to my exciting website, madameovary.com. We've got some exciting information there. And if you need a doc or a midwife or somebody like that who's trained, go to the menopause.org website, which is the Menopause Society website, plug in your zip code, and they will find you menopause trained people around your area. So, and there are people throughout the United States, so it shouldn't be a problem. And North America, I mean, there are people in Canada and Mexico, they're on the lists too. So that basically, if we have, if you need somebody who knows something about menopause, go to menopause.org, plug in your zip code, they will find you somebody who knows something about what they're talking about.
Dr. Minkin, thank you for joining us today. Thank you all to each of you who came to this call. You've really just enlightened our experience, and I'm sorry if I didn't get to all your questions. I do want to encourage you also to utilize your coupon on myalloy.com. Connect with a menopause trained physician there as well. You can take your question and drop it right over there to somebody who can help you out and get you some relief. It's always an educative and enjoyable experience with you, Dr. Minkin. Thank you so much, and I hope we get to speak soon.
Thank you for doing this, Kristen. I thank you for organizing as well. It's lovely. Thank you very much. And I wish the best to everybody listening, and hopefully you've learned something that'll be useful for you.
Absolutely. Thank you so much. Thanks, everyone. Be well. Bye-bye.
Bye-bye.